Well, thank you very much for listening or watching this presentation, my new presentation on an update on new tools or relatively new tools for the diagnosis of soft tissue tumors or cutaneous soft tissue tumors. I will have no relevant financial disclosures. So let's start with diagnostic tool 1. So myxoid liposarcoma typically presents as a deep-seated mass in the lower extremity of adults. So presentation, primary subcutaneous presentation is rare, but can happen. And as you can see here, this is an example of myxoid liposarcoma where the MRI shows a well circumscribed tumor in the subcutis with a clear plane of tissue between the tumor and the fascia. And then we have a well-circumscribed gelatinous tumor center in the subcutis, the gross picture, and abutting the epidermis. It showed classic histologic features. It shows a well-circumscribed myxoid neoplasm center in the subcutis. Well, you have the multilobulation separated by collagenous septate with hypercellularity along the periphery. The myxoid sarcoma cells are uniform. They're composed of these small hyperchromatic cells with a very delicate capillaries, the so-called chicken wire capillary. And in some area of the tumors, there was lipoblastic differentiation, but this is not that common. The differential diagnosis when you encounter a superficial myxoid liposarcoma can be broad, especially for the colleagues that don't see that every day. Myxoid dermatofibrosarcoma protuberance, a subtype, can be sometimes difficult to diagnose. This is infiltrating into the subcutaneous fat. It lacks the regular plexiform vasculature that you see in myxoid liposarcoma, and it doesn't show any lipoblasts. This was a case of low-grade myxofibrosarcoma who the cells do not show any significant atypia, but the vasculature is not this delicate plexiform vasculature you see in myxoid liposarcoma, but it's coarser, curvilinear vasculature, and the cells, if you look carefully, they look more atypical than myxoid liposarcoma, and they look slightly more pleomorphic. Spindle cell lipoma can cause diagnostic difficulties and can show significant myxoid changes, or called myxoid variant of spindle cell lipoma. But typically, the cells show mature adipocytes as well, and a stereotypical clinical presentation, albeit not all the time. And of course, you're going to see in the background characteristic roped collagen bundle. And they do have delicate vasculature. However, the plexiform pattern is not typical. Myxoid neurofibroma has a random rearrangement of the wavy spindle cells, but usually has some fine collagenous stroma. And the vasculature as well is not that of a typical plexiform pattern that you see in myxoid liposarcoma. But we know the genetics, we know the molecular pathogenesis of this tumor for many years. About 97% of the cases, they have a rearrangement, a fusion between the FUS gene and the DDID3 gene, and about 3% have EWS-R1 DDID3 fusion. And you can easily take most of the cases, not all of them, in the great majority of cases, with a breakup part of FIS for DDID3. However, especially in the cases with EWS-R1, the translocation can be cryptic, and you get a false negative EWS-R1 DDID3 that you should be aware of. However, based on that knowledge, a new antibody was developed, DDID3 immunohistochemistry, that works very well, and it shows this very clean, strong, diffuse nuclear positivity in cases of myxoid liposarcoma. And the antibody is a mouse monoclonal antibody that is directed against the N-terminus of the DD83. Because when they look at the fusion, the DD83 FUS or AWSR1 DD83, you have the N-terminal transcription activation domain of the FUS or AWSR1 that is fused with the entire coding region of DD83. And that, with that rationale, the antibody was created and shows, as we will see, extremely high sensitivity and specificity. And it works very well even in a high-grade liposarcoma that, especially if you have a small sample, does not resemble a classic mixed liposarcoma low-grade, and can be occasionally difficult to diagnose if you don't see the low-grade component. And also when this is a very sensitive tumor for radiation therapy, and many times it's given in a neoadjuvant setting, and you can see here remnants of single tumor cells around the vasculature that they are highlighted by DD83 immunohistochemistry. Even in the cases, as I told you, that it's rare cases, but certainly existing cases that they can show a cryptic AWSR1 DD83 fusion, and therefore your break apart DD83 will be negative. In this case, it worked really well because the fusion is there, and obviously it can be detected much easier by RNA sequencing. So the tumor in the major study had 100% sensitivity, even in cases with high-grade component or neoadjuvant radiation. And in other cases, there were conceivably in the differential, the DD83 was focal, minimal, was not the diffuse strong positivity that you usually see in myxoid liposarcoma. So this is an antibody that further studies have been done, and it has a very high sensitivity, about 96% to 100% and 94 to 96%, and can be extremely helpful, and actually in the appropriate clinical pathologic context, pretty much avoid to do the molecular. And the other thing you have to remember, you may have the primary cutaneous, subcutaneous myxoid liposarcomas that are rare, but also myxoid liposarcomas is notorious for having a propensity to metastasize in other soft tissues. So you may have as a first presentation a case of myxoid liposarcoma, and then detect a primary tumor that it was not known, let's say in the proximal thigh, which is a very common location. And sometimes if you have a funny or a very myxoid spindle cell lipoma, the differential can be a little bit difficult morphologically. So this is a tumor, a stain that can help you a lot. Diagnostic tool 2, let's start for the case. This was a 65-year-old female, had a 10-year history of a slow-growing subcutaneous mass. Outside institution, was diagnosed as hydrocarcinoma, then referred for excision with white margins. This is the case that was shared by my dear colleague, Dr. Masado, from Valencia, Spain. So this is the tumor from low power. It looks, it's a subcutaneous tumor, well circumscribed, unencapsulated tumor, kind of multinodular growth pattern separated by collagenous fibrous septate. You see in a high power, you can see lymphovascular invasion or tumor protruding into the vascular spaces. The tumor looks quite uniform with this cytologically relatively bland, round to ovoid hypercellular areas. And there were some tumor necrosis focally. Not a lot of mitotic activity was seen, and this is a high power. You can see this ovoid with relatively fine chromatin pattern with indistinct nucleoli, interspersed capillaries, and lymphovascular invasion. A lot of stains were done in the outside institution. They were all negative, and they did a FIS. They were negative for AWSR1, FUS, CIC, etc. And then they did NGS that showed this fusion with unknown significance. However, this tumor shows some patch positivity for MDM2, positivity for CDK4, and positivity for STAT6. And if you actually look at the chromosome 12, you see that these genes, the STAT6, DD83, GLI1, MDM2, they're all, we think, very close together in chromosome 12. And then further investigation of this case showed that had amplification of CDK4, DD83, the MDM2 was not amplified. It's a little bit further, and the GLI1 gene was also amplified. So this is a case of GLI1 altered amplified mesenchymal neoplasm. It's a relatively new entity, a hot topic. A lot of people are still working on this entity. And the GLI1 is actually familiar, the derm path community is familiar because GLI1 is part of the Hitchcock signaling pathway, where you have binding of the Hitchcock ligands to the patched receptor, the PTCH, which then alleviates the inhibition to smoothened, and then the smoothened translocates into the cilium and initiates a signaling cascade that leads to the release of the GLI1 protein from SUFU, and then the GLI1 moves into the nucleus and act as a transcription factor and the activation of transcription genes that are critically for basal cell carcinoma pathogenesis. And there are some evidence that depending on where you exactly, in which level you have the mutation, they may be correlation with the morphology. For example, if you develop cystic type basal cell carcinoma, they are more common having mutations in the SUFU gene, where PTCH they look more of the classic basal cell carcinoma. And people have used this knowledge to see if they can differentiate the basal cell carcinoma from mimics. And there's a GLI1 RNA chromogenic in situ hybridization that people have used that works pretty well, that's separating basal cell carcinoma from mimics that are not of follicular derivation. You can see here that squamous cell carcinoma is negative, or this was an SCC of the lung metastasizing. It was negative. However, it's useful so to distinguishing between basal cell carcinoma and non-follicular epithelial neoplasm. However, it's not specific for distinguishing basal cell carcinoma from most benign follicular tumors. So you have to be aware of that possibility. But GLI1 fusions or amplifications have been described in mesenchymal neoplasms, and the whole story starts in 2004, where a tumor that was thought to be pericytoma at that time, 2 papers on the same year. However, as we know, these fusions are promiscuous, have been seen in different neoplasms across the board. GLI1 fusions have been seen in some rare gastric tumors, such as gastroblastoma and plexiform fibromyxoma. And then from Memorial Sloan Kettering, colleagues realized that there is a distinctiveness in a tumor which is very epithelioid and show GLI1 rearrangements and GLI1 gene fusions. And the data are so solid now that actually the GLI1 altered soft tissue tumor made it to the WHO book of the head and neck tumors. And this is some characteristic appearances that it can show this nodular or multinodular growth pattern similar to the case I showed you before. They have exhibiting these thick fibrous bands with background myxoid changes and peripheral infiltration into adjacent tissues. Occasionally, they can show some prominent cystic changes, or they can have subendothelial protrusions into the vascular places mimicking lymphovascular invasion. The cells, for the most part, but not always, but this is one of the classic morphologies, although the morphologic spectrum is quite wider. So this uniform round 12-oid morphology resembling glomus tumor with this distinct nested nests separated by these delicate capillaries. And they can show a recorded or reticular pattern as well, or cystic or sieve-like patterns in a myxoid background. Immunohistochemical is not very specific. SMA, despite the fact that it was initially called pericytoma, is not consistently expressed. CD56, although non-specific, is most consistently expressed. Synaptophysic chromogram typically negative. S100 can be positive in about half of the cases, but SOX10 negative. There's diffuse strong P16 positivity in many, many cases, and myopithelial, myogenic, or keratin markers are typically negative, but in the GLI1 amplified cases, MDM2, STAT6, CDK4 are commonly positive, similar to the case I show you. And there are some cases that are being reported in the skin. And we actually had 3 cases that we reported recently. And this was the second case where, again, you see this well-circumscribed multinodular tumor with ovoid to round cells separated the nodules by thick fibrous bands, and this was amplified and CDK4 and STAT6 positive. And this was another case that we had, again, these glomoid cells, but these look more atypical with atypical mitosis, and GLI1 amplified with MDM2 and CDK4 expression. This one was the first cases that was reported in the skin. Again, this glomoid pattern, multinodular with these round ovoid cells. The cells were positive for CD56, negative for S100 and CDK3, and also showed DDID3 amplification, which is very close to the GLI1 gene. And all the cases that have shown GLI1 amplification, they are DDID3 amplified. And that's important because if you want to prove it by FISH, this is widely available commercially. This was a case that was not amplified, but was fused in the skin. Again, this multinodular growth pattern with its glomoid cells. So every time you think, could this be a glomous tumor, or could this be some kind of adnexal tumor, hydroadenoma, typical hydroadenoma, hydrocarcinoma, and things like that, think about a GLI1 altered tumor. And this tumor was diffuse S100 positive, doesn't always do that, 50% are negative. And this one, another case, and again, this one doesn't, it's a shape biopsy, you can't appreciate the multinodularity if it was there, but you can see these ovoid, small glomoid cells. So we have now a new tool that could help in the appropriate clinical pathology context to avoid doing the molecular studies, and this is GLI1 immunohistochemistry that works very well in the amplified cases and the cases fused. It shows diffuse strong nuclear positivity, and has a very high sensitivity. It shows 93.1 positive in this big study, 21 of 23 cases, and other cases that they were not really in the differential diagnosis, but show some positivity are other sarcomas. And the reason is because GLI1 can be gained or be amplified in other tumors as well, other sarcomas, and the correlation between copy numbers of GLI1 and immunoexpression seems that doesn't exist. We're not quite sure why, but be aware that some other tumors can show GLI1 because the GLI1 is gained or amplified, therefore reducing the specificity. But however, many of these tumors would not be in your morphological differential, at least for the typical cases of GLI1. Diagnostic tool 3, this is your classic DFSP. I don't have to show you a lot, but there are a lot of variants of DFSP that can create some potential diagnostic difficulties. So some cases can show myoid nodules, some cases can show infiltration into the skeletal muscle, can show this multinucleated floret-like degenerative cells, epithelioid cytomorphology. Cases are curvilinear vasculature that may resemble a high-grade myxofibrosarcoma or even a low-grade myxofibrosarcoma. However, in difficult cases, we know now the molecular pathogenesis that this tumor is COL1A1 PDGFB fused, either through a reciprocal translocation or more often through a supernumerary ring chromosome. And about 5% we knew they were negative for PDGFB rearrangements by FIS, and these were either because they had a cryptic translocation or because they have alternative PDGFB fusions, but the functional mechanism is similar in PDGFD and PDGFB fusions. And the PDGFD are interesting because some of the DFSPs, they don't have this classic infiltrated infiltrating growth pattern, but they are purely subcutaneous and they are very well circumscribed rather than infiltrated. And seems that many of these cases are rich in PDGFD fusions. And we have a new tool, the PDGFB RNA in situ hybridization, but people have worked on and actually works pretty well. But you have to validate it very carefully in your lab and show this punctate or aggregates within the tumor cells. This is some examples that you show that are positive for PDGFB RNA in situ hybridization. And of course, for the most part, if you look at classic DFSP, you don't need molecular, you don't need RNA in situ hybridization, you don't need any of these. But there are some cases that are difficult, especially the cases that have fibrosarcoma transformation, or if it had metastasized as a fibrosarcoma pattern. And this case can be difficult and can be extremely important because now we have targeted therapy that then may give some solutions to clinicians in terms of surgical planning and, of course, treatment in metastatic disease. And actually, in fibrosarcoma, this actually worked. It had way more intensity, and that is not unexpected because when we have fibrosarcoma transformation, the fusion, there is a gain of that fusion protein gene. So we have a lot of signal, and the cases, of course, that the PDGFD rearrange did not show predictably signal for RNA in situ hybridization for PDGFD. So it had a really high sensitivity. The one case that it was negative, it was actually a PDGFD rearrange. And other tumors are some a little bit focal, but not that diffuse, didn't meet the criteria for positivity by any means. And you have to be careful to see that there are within the tumor cells because the PDGFD is expressed within the endothelial cells. Diagnostic tool 4, primary synovial sarcoma, as you know, involves frequently deep soft tissue of the extremities in young adults. However, there are genuine superficial synovial sarcomas within the dermis and or subcutaneous tissue. To give you some examples, this is a biphasic neoplasm of spindle cells and glandular formation, and this was a monophasic spindle cell tumor with occasional mitotic figures. And so far, we didn't have a specific immunohistochemistry. There could be MA positive, keratin positive. It doesn't happen all the time. It can be a really difficult diagnosis when they get what we call poorly differentiated, resembling any other round cell undifferentiated sarcoma. However, we know the molecular genetics and the translocation, the hallmark translocation is between X18, which fuses the SS18, formerly SYT gene on chromosome 18, with SSX gene, SSX1, 2, and rarely 4. So based on that knowledge, the new generation of immunohistochemically, the development and characterization, we developed 2 novel antibodies. One, the E9X9V, a rabbit monoclonal antibody targeting designated at the breakpoint, and then a rabbit monoclonal antibody, the E5A2C, which is an SSX specific antibody. And it works extremely well. The SS18 SSX has perfect sensitivity, specificity, and about 95% sensitivity, and SSX has perfect sensitivity and a little bit less specificity. And this nice example works really well, diffuse, strong nuclear expression in the spindle cell component and the glandular component. This was a hypocellular monophasic synovial sarcoma. You can imagine it could be diagnostically difficult, diffusely and strongly positive for SS18, SSX. This is more myxoid, resembling a solitary fibrous tumor, perhaps, or some other myxoid tumor, diffusely positive. This was a poorly differentiated synovial sarcoma. In this case, was negative for SS18, SSX, but it was positive for SSX. So people have validated with a lot of tumors, and it's a very, very sensitive and very specific when you're using conjunction. for the most part, most of the times, in the great majority of the times, you can done with just the SS18, SSX antibody, and people have created algorithms. So if you have a tumor that your differential synovial sarcoma is positive for SS18, SSX, it's synovial. If it's negative for SS18, SSX, and positive for SSX, it's probably synovial. Proceed with FIS. If it's both negative and it really looks like synovial sarcoma, you have to start thinking if there are any confounding factors, poor fixation, decalcification, etc. If they are, proceed with FIS. If they're not, then you are out of the hook. It's not synovial sarcoma. It is something else. And this belongs to what we call next generation immunohistochemistry, where there are many antibodies that they're based on the molecular pathogenesis of the tumor, and they work very well. In some instances, better. In some instances, less well. Depending, they don't have all the same sensitivity and specificity, obviously. Diagnostic tool 5, pseudomyogenic hemangioendothelioma, intermediate biologic potential, propensity for local recurrence, but rarely metastasize. And it looked like cellular benign fibrous histiocytoma, perhaps, if you see that on 1X very fast. It has these seeds and loose fascicles of spindle cells with abundant brightly eosinophilic cytoplasm, vesicular nuclear and small nucleoli, with low mitotic activity and no significant cytologic atypia. Again, looks pretty infiltrative, looks quite pink from medium power with these intersecting fascicles, and it has this myogenic look, but it doesn't stand for myogenic markers. And another, which can be a clue in about 50% of the cases, has intermingled neutrophils, which can be a clue to the diagnosis, but can create some confusion because of its immunohistochemical. It's positive for cytokeratin, it's positive for ERG, but it's negative for CD34, and CD31 is variable. So if you don't do ERG, you're not going to pick it up. And of course, because it's cytokeratin positive, you start thinking about epithelioid sarcoma, maybe hence the old name epithelioid sarcoma-like, but the INI here is retained. And has shown, the molecular pathogenesis has shown FOSB fusions with a bunch of different partners. SERPINE1 and ACTB are the most common partners. And now we have a diagnostic marker. We have an immunohistochemistry for FOSB that people looked specifically for pseudomyogenic hemangioendothelioma, and it works really well. It was about 96% positive in a pseudomyogenic hemangioendothelioma with good crispy nuclear expression. And the other thing you should be aware of is in your differential epithelial hemangioma, that was half of them were positive, and because we now know that epithelial hemangiomas can show FOS and FOSB rearrangement. So FOSB doesn't have perfect specificity, but I think in the appropriate clinical pathologic context, you may actually, it's very helpful and may actually avoid doing molecular if it looks characteristic for pseudomyogenic hemangioendothelioma. As I said, the specificity is not perfect because you have to be aware that FOS gene rearrangements can also be seen in epithelial hemangioma, and FOSB can stain other vascular tumors as well. But I think in the appropriate morphologic context can be a very helpful diagnostic tool. Diagnostic tool 4, low-grade malignant vascular neoplasm epithelioid hemangioendothelioma. It behaves less aggressively than angiosarcoma, but still can kill the patient with about 15% mortality rate in reported cases. And most commonly, you're going to see that in the lung and liver, but there are genuine cutaneous epithelioid hemangioendothelioma. So typical features, so you have the sheets of epithelioid cells growing in a myxohalin background and showing cytoplasmic vacuolization, the so-called blister cells that may or may not have some erythroid red blood cells. And sometimes they have this vasculocentric pattern, which is more common in non-cutaneous, but you can see that in cutaneous occasionally, as you can see here, it can be very helpful diagnostically. And again, the epithelioid cells with blister morphology. These tumors, like any epithelioid vascular tumor, can express keratin, can be confusing. So you want to be careful that you're not dealing with a vascular neoplasm. But we know now the molecular has, for the most part, approximately 90% of the cases, WWTR1, CAMTA1 fusion. And a subset of them that they have not been reported in the skin show YAP1 TFE3 fusions. And we have now an antibody, CAMTA1, which looks very well, has a very, very high sensitivity. And it's in the appropriate pathologic context, it really looks like epithelial hemangioma, stains like a vascular tumor. You want to prove it, you may actually do the stain and don't have to do molecular. In this case, 86% was positive of the cases. Some of them were negative because of decalcification, and one epithelial angiosarcoma, especially the ones that are high grade, it was probably a misdiagnosis, and it was a malignant, a high grade, let's put malignant epithelioid hemangioendothelioma. You have to be aware, although this has not been seen in the dermatopathology world, that some WWTR1 fused hemangioendotheliomas, they don't have CAMTA1 as a partner. So expectedly, this immunohistochemistry will not pick this up, but it has never been reported in the skin so far. Diagnostic tool 6, superficial CD34 positive fibroblastic tumor, discovered about a decade ago. I was honored to be part of the initial paper when I was a fellow with Sharon Weiss. And then more people follow, and the important thing is to not call these as high-grade sarcomas because they look very ugly. They're all superficial, suprafascial, and they have this pleomorphic spindle cell morphology infiltrating into the subcutaneous tissue. They look very ugly, very pleomorphic, irregular nuclear contours, some phomatized cells, very pink. But if you look carefully, you don't see mitosis, and that is very, very unusual. Hence, the old diagnosis, some people were calling this low-grade UPS. This tumor has some peculiarity. CD34 is not, of course, a specific marker, but this tumor is constantly diffusely positive for CD34, and that is very unusual. And most of the tumors that they belong in the differential with this tumor, they don't show this constant diffuse CD34 positivity. It also can show some patchy expression of cytokeratins. You have to be careful, and Desmond. And people a bit later published the PDRM10 rearranged soft tissue tumors, and they look awfully similar comparing to the superficial CD34 tumors. So now we think that these tumors, we believe that these tumors belong to the same spectrum. And when people did gene expression analysis, all these superficial CD34 either were rearranged or not, they are clustered together. So that's further evidence that they are a separate entity. But then interestingly, from a gene expression analysis, the CAMDM3 protein was up in the roof. Of course, and we have an immunohistochemistry now, the CAMD3, that works really well in conjunction with the less specific CD34 positivity. And recently, the ultimate paper was published, 59 cases that show, in many cases, this diffuse CAMD3. And also, although this is not specific, it's very unusual in soft tissue tumors to see this diffuse WT1 expression, nuclear expression. So that's very unusual. So that is also a potential diagnostic tool for this tumor. So 95% expression out of the about 168 cases or so published, 100% of CD34. Both of them can be used to make the appropriate diagnosis and avoid the pitfall to call this, to label this patients as having some kind of high-grade sarcoma, pleomorphic dermasarcoma, etc. Because for the most part, they behave in an indolent fashion. They can metastasize, but very rarely have metastasized to the lymph nodes, but they haven't, so far we don't have any death. So theoretically, I mean, strictly, it is a tumor of intermediate malignancy, less than 5% so far metastatic rate. And this is pretty established by now and has made it to the new WHO of the skin tumors, the 5th edition, as a separate chapter. Clear cell sarcoma as a diagnostic tool 7. Of course, clear cell sarcomas are more common in deep soft tissue of the foot and ankle in younger adults, but they are genuine cutaneous clear cell sarcomas. And the main pitfall is not to call this melanoma or Spitz tumor, Spitz nevus, etc. They look very uniform, spindle cells with collagenous background with this prominent cherry red nucleoli, and they stain like melanocytic tumors, S100, melanA, shock-stem, etc. But there have been mistakes in this tumor. This was a dreadful case many years ago, was misdiagnosed as Spitz-Nevis because it had dermoepidermal colonization, which has been described. And of course, after a few years, has shown gross metastasis, and compound clear cell sarcoma is a known something that can happen. And actually, this was epidermotropic metastasis of clear cell sarcoma. But we know the molecular pathogenesis. They show EWSR1 rearrangements with ATF1, CREB1 most commonly, and CREM rarely. But I wanted to show you a diagnostic tool that can be helpful avoiding further molecular studies if you entertain the diagnosis of clear cell sarcoma. PRAME, of course, has imperfect sensitivity and specificity, but it works pretty well for melanomas. But PRAME in clear cell sarcomas is consistently negative. Very few focal, but consistently negative. People have looked at this, and actually that makes sense because we know that 20 years ago, that PRAME is one of the most down-regulated genes in clear cell sarcoma. Therefore, if you have a tumor, you say, man, could this be a clear cell sarcoma? Shall I do a FISI-WSR1? I'm not sure if it's PRAME diffusely positive. It's not clear cell sarcoma. It's probably melanoma or something else. But if it's PRAME negative, of course, that doesn't exclude a melanoma or something else because of the imperfect sensitivity of the marker. Diagnostic tool 7, superficial angiomyxoma, a multinodular myxoid-rich tumor arising in dermal and superficial subcutaneous tissue, has a tendency for local recurrence. And the main thing is to avoid misclassifying it as some kind of low-grade sarcoma, such as low-grade myxofibrosarcoma. And we know that cases of superficial angiomyxoma, they are related with carne complex, which shows germline mutations in the PRKAR1A gene. And we also know that the majority of superficial angiomyxomas can happen in the sporadic setting. So this could be a sporadic or could be an opportunity to detect cases of carne complex, especially when you see it in eyelids or the external auditory canal. This shows this multilobulated plexiform growth pattern where there's a lot of myxoid background and delicate background, small capillaries. And many times this tumor has infiltrative neutrophils, which can be a clue. But we know now that the PRKA1 mutation is not just in superficial angiomyxomas, but also in the sporadic superficial angiomyxoma. And your main differential, if you see it in the skin, of course, would be acrofibromyxoma, distal fibromyxoma. This one, the acrofibromyxoma, has a striking periangle, a location which is uncommon in superficial angiomyxoma and is more cellular. And also superficial angiomyxoma can be seen in genital sites, which the principal with a diagnostic consideration would be a deep aggressive angiomyxoma. So the immunohistochemical pattern is not specific, sometimes can express CD34, sometimes not, but we know now because of the molecular pathogenesis of the carne complex associated and sporadic superficial angiomyxoma that they show loss of PRKAR1A immunohistochemistry. And this is a case you have a nice internal positive control. Sometimes this tumor has a lot of mucophages, a lot of histiocytes, and the PRKAR will be retained there. So you have to be careful to make sure that the tumor cells are lost. So sometimes if it has a lot of mucophages, you may want to correlate it with the PU1, a nice nuclear histiocytic marker, to actually see which cells are actually the tumor cells. Diagnostic tool 8, just a slide. This is a teaser for a sequel because it's not yet clinically primed, but it's coming. There's a methylation classifier that works pretty well. It's in clinical practice in brain tumors. It works very, very well. And now there's a hot topic. Many people work on how can we use the methylation classifiers to classify sarcomas. And for example, in dedifferentiated, transdifferentiated, or undifferentiated melanomas, where many of these were called sarcomas because we had no way to prove that they were melanomas. Actually, there are promising data, very strong data, that the methylation profile works very well in these circumstances. Thank you very much. This is my email. This is my Twitter. I tweet only for medical reasons. And this is my channel. And please ask your friends if you think these were helpful and they're interested in the topic to subscribe to the channel. Thank you very much and see you next time.